Okay. So thank you really for staying. It's a really very cold day, and I really apologize for that. Now what I'm going to talk to you about is about arthritis. It's really an introductory lecture, and then we'll have the other lecturers giving you solutions for it. I have no disclosures. So as everybody knows, you've talked about it all day. The shoulder is a very complex joint. It's got the greatest range of motion in the body, and it needs tendons, muscles, and ligaments in order to be congruent and stable. So what's arthritis? It's a degenerative joint disease that causes pain and restriction in motion. It's gradual and it's progressive. It's a mechanical and biomechanical breakdown of the articular cartilage and other joint tissues, including bone and the joint capsule. So it causes pain and restriction of the range of motion, and this can lead to activity limitation, job performance problems, unacceptable quality of life, and even depression and anxiety. What's the reason? Well, it's mainly, arthritis is mainly primary, where the reason is unknown. But we also have secondary arthritis. It can be due to inflammatory reasons, crystal arthropathies, after an infection, after rheumatoid arthritis. It can be after trauma, after fractures or dislocations, after surgery, if we've done a very tight anterior capsule, or if we have intra-articular hardware after a fracture. Also after avascular necrosis, and the different reasons for that. And finally, we have rotator cuff arthropathy. Most of the cases, as I said before, are primary, now about 90% of the cases. And we have some risk factors, like repetitive motion injuries due to shoulder overuse, different occupations that involve excessive use of the upper extremities, sports that have a lot of overhead activity like basketball or volleyball, any history of trauma, luxation, and genetic factors, female, gender, and age over 60. In order to diagnose it, very important is the medical history. Physical examination, we need to identify the points, the sites of pain. We usually will find a very painful active and passive motion, or also a restriction in the range of motion. Also, you can find crepitus, decreased strength, loss of scapular rhythm, and a joint effusion. Going on, we can do, for imaging, X-rays. You can do an AP X-ray, where we can see the narrowing of the joint space, see any osteophytes, subchondral sclerosis, or even humeral head migration. And also the axillary view, where we can actually see the glenoid erosion or glenoid version. Even better, doing a computer tomography. We can evaluate the glenoid anatomy, erosion, version, and we need this usually for a preoperative planning, checking for any bone defects. MRI is also very useful, where we can evaluate the rotator cuff integrity, check for any fatty degeneration. It's less accurate than the CT scan in distinguishing the different glenoid types. And finally, we might need to do any blood tests like inflammatory markers, blood count, or rheumatoid factors in order to exclude any of the inflammatory causes. There's different classifications. One of this is Walsh classification. We take into account if the head is centered or not, if we have any retroversion, or if the head is sublux posteriorly. I won't go into details. We need to rule out any other causes of pain, on stiffness, like tendonitis of the long head of the biceps, rotator cuff tears, adhesive capsulitis, frozen shoulder, any subacromial impingement, AC joint arthritis maybe, or even referred pain from the neck. These also can coexist with glenohumeral arthropathy, of course. Now, the natural history, well, it's, as I said before, it's a gradual degradation of the articular cartilage. We have matrix fibrillation, fissure appearance, gross ulceration, and then full thickness loss of the joint surface. This is accompanied usually by osteophyte formation, subchondral plate thickening, and also synovial membrane thickening and inflammatory reaction. The diseases progress usually in 3 stages. Initially, we have a proteolytic stage with a breakdown of the cartilage matrix. We can have then, as we said before, fibrillation and erosion of the cartilage surface, and then we have different products that in the 3rd stage, through phagocytosis, we have the production of proteases and the pro-inflammatory cytokines. Now, to go on, rotator cuff arthropathy is quite interesting, is one of the causes of arthritis. It's a specific pattern of shoulder degenerative joint disease. It was first described in 1983 by Neer, and we've got a loss of joint congruence on abnormal glenohumeral wear. So the rotator cuff plays a very important role in the stability of the shoulder. A tear in the rotator cuff and its progression to become massive may result in the loss of the dynamic stability of the joint. So we've got rotator cuff insufficiency, we can have superior migration of the humeral head, altered mechanics, glenohumeral cartilage destruction, subchondral osteoporosis, and even humeral head collapse in later stages. Now, according to Neer, the natural history, we usually have initially a massive rotator cuff tear, and then we can have mechanical and nutritional factors that lead to the cuff tear arthropathy. Mechanical factors like loss of the concavity due to the compression effects, decreased range of motion and shoulder function, humeral head migration, and instability with possible recurrent dislocations. And nutritional factors are usually due to the loss of the watertight joint space. So we have loss of fluid and nutrients from the joint, and this can cause cartilage atrophy. There's also another theory, like the crystal-mediated theory, where they believe that hydroxyapatite crystals and the phagocytosis is the cause of the degenerative process, destroying and the cuff and also the joint. There's a Hamada classification of the rotator cuff arthropathy that takes into account mainly the acrohumeral distance, and also if we have acetabularrization of the acromion. I won't go into details. This is a picture of a destroyed, really, shoulder from rotator cuff arthropathy. So treatment. What are we trying to achieve? Less pain, more function. We can do that with conservative treatment or surgical treatment. So conservatively, initially, we might need to do some activity modifications, mainly avoid painful activities, and then we can do physiotherapy. That's where we need you, is we're trying to increase range of motion, trying to keep the joint moving and stretch the soft tissue, and of course, decrease pain. We can help with medication, painkillers, non-steroidals. If you've got rheumatoid arthritis, you might need to give disease-modifying medications or steroids, or even local injections like hyaluronic acid, biologic therapies, and corticosteroids. As it concerns surgical therapy, we can do in the initial stages, we can do like an arthroscopy for a joint preserving surgery, maybe to delay an arthroplasty, but later on, probably might need a shoulder replacement surgery. We've got different kinds, like hemiarthroplasty, total shoulder replacement, or reverse shoulder replacement. In arthroscopy, what we'll probably do is try and remove free bodies, remove any free cartilage flaps, smoothen cartilage surfaces, do synovectomy in initial stages of inflammatory diseases, and may address other causes of pain like the log head of the biceps. Usually it's a temporary solution. When do we go on for a shoulder replacement? Well, significant pain, failure conservative treatment, if the quality of life is not acceptable, and if painkillers are no longer effective. Different kinds of arthroplasty, you'll hear all this later. We can do resurfacing, total shoulder replacement, reverse shoulder replacement. You can see some x-rays of this. What to choose? Well, factors to take into consideration is the age, the activity level, if the rotator cuff is intact or not, on the bone stock of the glenoid. So in conclusion, glenohumeral arthritis is a common cause of pain and restriction of range of motion, causing functional disability of the shoulder. It's a complex joint disease with different factors causing it. It represents a set of pathologies with clinical manifestation and morphological and radiological changes. And depending on the symptoms, the severity of the disease, we can decide if we can have conservative or operative options. So our aim is no more shoulder pain. Thank you very much.